My name is Naresh Bumma. I'm a hematologist at the James Cancer Ohio State, and I will be talking about BCMA-directed bispecific antibodies. I will review the latest data, including EHA, ASCO, and ASH, and we'll discuss the integration into the current multiple myeloma treatment landscape. Um, so let's start with a clinical case. So this is actually a patient of mine. She was diagnosed when she was 65. She presented with cytopenias, WBC count of 2.7, platelet 121, hemoglobin of 8.2. Her physician did a myeloma workup. She was found to have a monoclonal protein of 4 grams per deciliter, total IgG of 57, 100 milligrams. Kappa, normal at 9 milligram per liter, lambda 0.69 with a ratio of 13.2. Beta hemoglobin was 5.59, albumin less than 3, calcium was normal, creatinine was within normal limits, LDH was 153. She noted a bone marrow biopsy that showed 50% plasma cells, and notably FLISH showed translocation of 1416. She had a PET scan, which showed diffuse bony lesions in the humerus, femurs, right anterior ribs, and left sacrum. So she was diagnosed with IgG kappa multiple myeloma, ISS stage 3, with translocation 1460. So how we treated her, which I think it would be somewhat similar to what a lot of you guys would do out there. So she was started on induction therapy with a combination of bortezomib, lenalidomide, dexamethasone. She had 4 cycles. Best response to therapy was a very good partial remission. She then proceeded to high-dose chemotherapy and autologous stem cell transplant, melphalan 200. After which she was put on maintenance therapy with lenalidomide at 10 milligrams, day 1 to 21 of a 28-day cycle. She was on that for about 2 years. Her best response was VGPR. She then had biochemical progression, and therapy was switched to combination of daratumumab, bortezomib, and dexamethasone. She did fairly okay with that. Best response was a partial remission. She then was switched to a combination of carfilzomib, pomalidomide, and dexamethasone. Um, Best response, again, very good partial remission, and then therapy was stopped due to biochemical progression. So she was then referred to me, and we discussed what the next step of therapy would be. So for her, we decided to move on to a bispecific T-cell engager targeting BCMA. So if we look at the myeloma pathway or the treatment landscape for multiple myeloma, we know that most patients will start with a pre-malignant condition or like a smoldering myeloma or MGUS, and that will present with symptomatic myeloma. They then undergo induction, followed by consolidation, followed by maintenance. And depending on how aggressive the disease is, you can have early relapses, or you can have later relapses, with triplets giving anywhere between 2 to 7 years. But then with each line of therapy, you see that the patients eventually do relapse, and then the treatments are not as effective. And what I mean by that is that the duration of response gets less and less impressive as we go along. Um, and then in later relapses, the survival is less than 12 months, and usually we end up recycling a lot of the previous agents we've seen. And this is where a lot of the T-cell engagers have, T-cell engager therapy has shown approval with bispecific antibody as well as CAR T-cell. So looking at T-cell engagement to relapsed refractory multiple myeloma. So on the right here, we see the plasma cell, and Dr. Lonel has already kind of gone through a good chunk of these, and you can target the T-cell activity with a few different ways. There's antibody drug conjugates that can directly bind to it. You have your T-cell bispecifics, you have your CAR Ts, and we'll focus mostly on the bispecifics. So the bispecific antibodies simultaneously bind to myeloma-specific antigens on myeloma cells and to the CD3 on T cells. The antigens that are being discussed, BCMA, SLAMS7, GPRC5D, and FCRH5. And Dr. Krishna will go through the others, and I'll focus on BCMA. Upon activation, there's T cell activation, proliferation, and differentiation, which leads to a lot of inflammatory markers with increased level of granzyme B, interleukin gamma, IL-2, IL-6, IL-8, and TNF alpha. And BCMA is sort of like Dr. Lonel mentioned, sort of like one of the good antigens, or probably, let's say, near to ideal antigens, because it is heavily expressed on the plasma cell, and it is very a good target for it. So if you look at the currently approved list of T-cell engaging therapy for relapsed multiple myeloma that is approved by the FDA, we have idacaptogen and cetacaptogen, which are both CAR T-cell therapies, and then we have teclistamab and elranatamab that are bispecific T-cell antibodies against BCMA, and then we have talquetamab, which is a bispecific antibody against GPRC5D. They're listed here in the order in which they were approved with the approval dates to them. So our patient ended up starting on therapy with teclistamab. So we will start with, let's start with teclistamab as our first drug. So if you look at during ASCO 2023, there was an update on the MajesTEC-1 trial by Dr. Van der Dong, and this was a phase 1 dose escalation, dose expansion trial. They enrolled patients with triple exposed refractory multiple myeloma, so they had to be exposed to IMiDs, PIs, and an anti-CD38. They had to be BCMA naive. In the phase 1 portion, there was both IV and subcutaneous teclistamab. And then in the phase 2 portion, they then found a dose of 1.5 gram per kilogram of sub-Q teclistamab. And then that's what the phase 2 cohort was on. There was an option for responders to switch to every 2-week or 4-week dosing down the line. The primary endpoint was overall response rate, but then also looked at PK, duration of response, progression-free survival, overall survival, MRD, and QOL outcomes. So this study enrolled about 165 patients, looking at some high-risk features. 12% of them had ISS stage 3 and 17% of them had EMD. They were all triple class exposed, and 70% of them were penta exposed. 78% of them were triple class refractory, and about 30% of them were penta refractory. So if we look at the overall cohort here on the left side, the overall response rate was 63%, with more than with 45% having a CR or better. But then if we were to subdivide them into the number of lines of therapy they had, those who had 3 or less prior lines of therapy had an overall response rate of 74.4% compared to those who had 3 or more prior lines of therapy, which was 59%. And that kind of maybe gives an indication that, BCMA therapy should be looked at in earlier lines. The median time to first response was 1.2 months, and the median time to achieving CR or better in those that it did was 4.6 months. Looking at PFS, the PFS was stable at 11.3 months for all patients. And then when they subdivided that into patients who had 3 or less prior lines of therapy, median PFS of 18.1 months as compared to 9.7 months in those who had 3 or more prior lines of therapy. In those who were MRD evaluable, 81% of MRD evaluable at 10 to the power minus 5. Looking at the duration of response at the right side, we can see that there is a good duration here with median overall of 11.8 months. But then if you look at those who had CR or better, it was 26.7 months. So that tells us that the depth of response definitely matters in this population. Now, obviously, we also worry about safety. So with a median duration of about 8.5 months, the most common AEs were cytopenias, infections, and cytokine release syndrome. So looking at the cytopenias, neutropenia was 71.5%, but grade 3 or 4 of 65.5%, anemia 54.5%, with 37.6% being grade 3 or 4. Infections were 80%, with grade 3 or 4 being 55.2%. Cytokine release syndrome was 22.1%, but only 0.6% with grade 3 or 4. ICANS were 3%, with none of them being more than a grade 3 or 4. Hypogammaglobulinemia was seen in about 20.6% of patients. 1.8% of them were grade 3 or more. 8 AEs led to discontinuation, 5 of which were infections. 7 treatment-related deaths were seen due to COVID, and all cases of ICANS resolved by the time the study had completed. So again, and with newer kinds of therapy comes your side effects, and being able to recognize them and intervene early on is very important. So the other study that I wanted to highlight was this presentation by Dr. Nuka, who presented a pool analysis of single agent elranatamab in patients who had prior BCMA therapy. I thought this was very interesting paper abstract to discuss because patients, a lot of them in our practices have already been exposed to BCMA, be that in ADC or CAR T, and whether or not we can re-challenge that patient population with a bispecific against BCMA. So in this one, it was elranatamab. They collected data from these 4 studies here for a total of 87 patients with relapsed refractory multiple myeloma, all of which had either had previously a PI, an IMiD, an anti-CD38 antibody, and 1 BCMA-directed therapy, either a ADC or a CAR T. The median follow-up was about 11.3 months, looking at the high-risk factors, so 23% were revised ISS, 27% had prior ADC, high risk was 24.1%, and then EMD was present in 54%. So if we look at all of the patients here, with any prior BCMA therapy, overall response rate of 46%, prior ADC 42.4%, prior CAR T 52.8%. Again, if we look at a CR or better, 18% in all, 18% in prior ADC, and similarly close to 18% in prior CAR T. Median duration of response was about 17.1 months in all. 13.6 is slightly lower in the prior ADC and not reached in the prior CAR T. Similarly, the median PFS was 5.5 months in all therapy, 3.9% in prior ADC, and 10 in prior CAR T therapy. Mean overall survival, 12.1 in prior BCMA, all of them, 12.1 in prior ADC, and 12.1 in prior CAR T. So infections were reported in about 73.6%, 26.4 of them were grade 3 or more. COVID-related deaths were COVID-related adverse effects were reported in 25.3 patients, and in about 6.9 patients, they had permanent discontinuation due to infections. So again, what this study kind of alludes to is that, we can recycle the BCMA antigen, and there has to be a careful selection. But similar to what I mentioned with the previous drug, is that antibody mediated off-target effects, especially in terms of infection, are very important to keep an eye on because those can be very significant in this patient population. The other study I wanted to mention was the Linker MN1 study. This was presented by Dr. Jagannath at ASH 2023. So this is with linvoseltamab, which is another BCMA-directed antibody. It's an IV dosing. So this one, the study design was for patients with relapsed refractory multiple myeloma, triple refractory disease, with exposure to at least an IMiD, PI, and anti-CD38 antibody. There are 2 step-up doses at 5 milligrams and 21 milligrams on day 1 and 8 respectively, followed by a 200 milligram once-a-week dosing up to 14 weeks. And then after that, there was an option of they go to every 2-week dosing. And then after week 24, for those who had VGPR or better, they could go to even an every 4-week dosing. The key objectives, the primary objective is an overall response rate, and then key secondary objectives for overall response rate by investigator assessment, duration of response, progression-free survival, MRD status, and overall survival. So looking at the baseline characteristics, here are a few things I would like to highlight. They did have about 26% of patients who were older than 75. There was about 17% of the patients who were African American or Black descent, which is very important to note, underrepresentation of minorities in our trials. About 18% of them had ISS stage 3, 14.5% had extramedullary disease, 39% were had cytogenetic high risk, and about 23% of them had more than 50% plasma cell. The median prior line of therapy was 5. All patients were triple exposed, and 76% of them were penta exposed. 80% were at least triple refractory, and 25% were at least penta refractory. So looking at the response rates by the independent review committee. Overall response rate of 69.2, at a median duration of follow-up of 8.1 months. More than half of the patients was still ongoing treatment at the time of this data cutoff. 59% of patients had VGPR or better, and 39% of patients had CR or better. Median time to getting a partial response or better was 1 month, and getting VGPR or better was 2.6 months, and getting a CR was 7.6 months. There were 10 patients who had prior BCMA ADC exposure, and in those populations, the response rate was up 70%. And looking at MRD data, 10 to the power minus 5, in those who did have available data, the MRD rates were 51%. So looking at the swimmer's plot here, the one thing I would like to kind of bring to attention was the fact that it took about a month, give or take, for patients to start seeing responses. And also in those that do have responses, as seen by the ones in blue here, the responses tended to be durable, and they tended to deepen over time. And that's one thing that we need to kind of keep an eye with these kinds of therapies, is that it can take a while there for the patients to start responding to therapy. So we shouldn't be too hasty to just call non-response and lose that treatment option. Now, look, I wanted to highlight a few of the bispecifics that are out there that are against BCMA. So we kind of had talked about teclistamab earlier, but this is more data about teclistamab. So in the paper, the data published by Dr. Usmani and Dr. Murrow, we know that in a heavily pretreated population with a 5 prior lines of therapy, 78% triple refractory, 70% penta-refractory, we see an overall response rate of 63% and a CR rate of 39%, and median duration of response of 18.4%. Infection rate of about 76% and CRS about 22%. ICANS in 15% of patients. Elranatamab, again, another BCMA-directed bispecific, median in this paper by Dr. Lashokin and Magnetism 3. So it was a phase 2 study, median 5 prior lines of therapy, 90% triple refractory, 42% penta-refractory, overall response rate of 61%, complete response rate of 35%, median duration of 17.1%, infection 70%, CRS 58%. ABBV1 383, this was presented by Dr. Vij at ASH. It was a phase 1 multicenter open label, 3 or more prior lines of therapy with exposure to a PI, IMiD, and anti-CD38. No prior BCMA was involved in this, so they had dosing up with a final recommended dose of 40 to 60 for the phase 2. Again, median prior line of 4 prior lines of therapy, 82% triple refractory, overall response rate of 64%, complete response rate of 29%. Median duration response was not reached, infection of 44% and CRS of 21%. Linvoseltamab, which we talked about, BCMA-directed bispecific, median from 5 prior lines of therapy, 80% triple refractory, 26% penta-refractory, overall response rate of 69%, CR of 39%, infection 37%, and CRS 46%. And then alnactamab, BCMA directed antibody, there's expansion cohort here presented by Dr. Surley at ASH and then by Dr. Costa at IMS. It's a humanized 2+1 T-cell engager binding to BCMA, median 4 prior lines of therapy, 63% refractory, overall response rate of 53%, duration of response not reached. No ICANS, but they did have 1 episode of ICH. So what I wanted to bring with this is that sometimes when you look at the response rates, these are somehow hard to differentiate which one to pick, and you kind of have to look at the details. The things I'll look at is the triple refractory class status, the penta-refractory class status, the infection rates, the CRS rates, the neurotoxicity rates, the ease of the administration in terms of those of the mode, but also in terms of the schedule. But as you can see from my slide here previously, that it's hard to kind of pick one of them. And I think the next step is going to be combination therapy. So these are some of the few studies that are out there that I wanted to outline. The first one is the TRIM2 study, which was run by Dr. Delora at ASCO 2023, which is combining talquetamab with daratumumab. In this study, they had 5 prior lines of therapy, 61% were triple refractory, 24% penta-refractory, and overall response rate of 84%. Infection of 68%, CRS of 80%, and 2% neurotoxicity. Then there was the Majestic 2 study, which is 1 to 3 prior lines of therapy with a median of 2. They had to be exposed to an PI and an IMiD, and they had teclistamab being given with an escalating dose and then with a flat dose of lenalidomide and dexamethasone. It is to be noted that about 90% of patients were refractory to DARA and 28 were refractory to LEN. Median time to first response was a month, and they had good overall response rate of 94%. However, infection was 81% and CRS was 81%. And the last study is elranatamab, which is subcutaneous with Elran. And again, you can see here we do 5 prior lines of therapy, 18% triple refractory, 71% overall response rate, and AEs were about 97%. So with that in mind, we need to be careful about toxin mitigation. So infections can be anywhere between 60 to 80%. You have your viral infections, HSV, VZV, CMV. There's bacterial infections, your usual bacterial, but also PJP. Fungal, you have to keep track of the hematological side effects with transfusions, growth factors, maybe TPO, hypogammaglobulinemia, consider IVIG, cytokine release syndrome. We need to recognize this and have access to TOSI. And obviously the neurological side effects with ICANS needs to be closely monitored. So with that in mind, to conclude, the T-cell engagers therapies have had very high response rates in heavily pretreated populations. They're now being studies of alternatives in earlier lines of therapy and also in combination. We need to consider patient-specific clinical factors. Access is very important, and obviously patient preference is very important. Patients and providers should be educated on monitoring and managing AEs, including CRS and neurotoxicity. There should be adequate prophylaxis and management of infections. Duration of treatment is obviously another hot treatment. MRD may be key to approval in novel agents, so you need to keep an eye on that as well. And I think if I were to summarize this in one line, the future is bright for myeloma therapies and T-cell engaging therapies, and there's always room for new agents as well. With that, I thank you for listening to me.